Amazing. Thank you. And thanks everybody for being here. It looks like there's a pretty good crew for a webinar, which is amazing. I don't know if you guys can post questions or things in the chat if you like, but I can see the chat. So happy to respond if you have any questions throughout the talk. So I wanted to introduce myself. I'm Fred Wininger. I'm a neurologist and neurosurgeon. I lecture frequently about this abysmal condition that we love called seizures. And basically, what we're going to be talking about today is, yes, we'll focus on some of the drugs and some of the kind of novel approaches to seizures. But when I talk about seizures nowadays, what I really like to do is talk about communication. How do we talk to clients about these events? How do we make them feel empowered understanding of them and kind of twisting the idea of what a seizure is in their minds. So, um, it's a little less than interactive because I can't see you, but I imagine that you've seen a case of seizures recently. And so, well, let's start talking about these seizures themselves. Seizures are a pretty frequent clinical sign. In fact, they are the most commonly based clinical sign that veterinarians are presented with, if you can believe it or not. And epilepsy or seizures, rather, are 10 times essentially more common in dogs than they are in people. So it's incredibly frequent in the veterinary profession. So I can talk to you about the physiology behind seizures and blah, blah, blah. But ultimately, when you're talking to a client, how are you going to tell them about what a seizure is? Are you going to say to them it's a clinical manifestation of excessive hypersynchronous neuronal activity? No, of course not. So what's the plan? Well, the plan is to basically get them thinking about seizures as a symptom as opposed to a disease. And we're going to talk about how we do that and differentiate these symptoms or clinical signs from other things. Before we do that, a little quick reminder of why we're here in the first place. I'm a neurologist. I should love seizures, right? No, I hate them. I hate seizures. And the reason why I hate seizures is because they are a clinical sign that in and of themselves are dangerous, and they represent changes in the brain suggesting that something's not right, and we cannot cure them. It's the fact. We can't cure them, but what we can do is decrease their frequency, their severity, their duration, and make owners understand a little bit more about them. Now, this is a common clinical presentation that I like to share with you to set the kind of temperature to why we're having this conversation in the first place. Mikey, if you've ever been to any of my seizure talks, I talk about him every single time because he's such a great reminder about what this is all about. Mikey's a 6-year-old male castrated pit bull that I had been treating for seizures for a significant amount of time. And he was on a refractory epileptic, meaning he's on 3 different anti-seizure medications. And no matter how much we continue to up them, the seizures emerge and they tend to emerge in clusters. Anyone have a case like this before? I'm guessing you do. So this is the scenario. Friday afternoon, I'm leaving the hospital. I haven't been on a date with my spouse in a while. I want to get out of there. And as on my way out the door, the client service representative grabs me by the arm and says, wait, before you go, one thing. And I say, sure. And she says, Mikey just had another seizures. The owners are on the phone. And then I say to the CSR, well, what medications are we on? And she says, Keppra, phenobarbital, and potassium bromide. And then I ask her about the levels, and she tells me where the levels are. I'm like, darn, we don't have a lot of room to move. Okay, let's tell the owner to give an extra dose of Keppra, give an extra dose of phenobarbital, and let's see how things go. And then I walk out the door and I live my life and I don't think anything of it. And this next slide shows you Mikey's family's experience. So this can be hard to watch just to prepare you, but this is what's going on at home with Mikey. So it's, the afternoon. They've just come back from work and Mikey is there and they're holding him because they know what's about to happen and he's having a generalized tonic-clonic seizure. If you could hear what's going on in the background, mom is screaming at dad, did you forget to give the meds? Dad is like, no, I'm just trying to make it better. He gets bitten. The other dog almost gets bitten. And they live this experience for 2 minutes. And then it's going to end. And then Mikey's going to run around the house, bumping into walls, eating everything in sight. And then we think to ourselves, okay, but they got through the seizure, right? No, these people are about to have a sleepless night because they know that Mikey invariably has 3 or 4 or more of these events whenever he has a single one. These people don't go on vacation anymore. These people don't go on date nights anymore. They got a dog for the love of animals, and they've essentially developed this experience where their life has been flipped upside down. It is this experience that requires our inherent empathy and compassion. There is nothing like having a dog with seizures. And I'm going to show you some data in a little bit that proves my point. Believe it or not, owners of dogs with seizures have stress levels that are literally 30% more than the rest of the population. My clients tell me they walk into the room and they're constantly waiting for the other shoe to drop. Here's a test for you. Next time you have a client, whether it's a first time or a fifth time client that you're treating their dog with epilepsy, don't go straight into the history. Don't go straight into the physical examination. Sit on the floor with them, look them in the face, and say, you know what? I've never had a dog with epilepsy. Tell me what's that's like. I bet you they start crying. I bet you they start telling you about how it's changed their lives and how they're always worried they're not doing the right thing by their dog. And it will give you an understanding about why this is more than just pushing a bunch of drugs and hoping they work out. Okay. Soapbox over, TED Talk beginning. We're going to talk about seizures. Now, the first thing you have to do when you start talking to somebody about a seizure is you need to figure out if it's a seizure. You want to piss somebody off, have a client come in, they will tell you my dog's having a seizure, and you say, but is it really? And then you start interrogating them about the seizure, and they'll get mad because they know their dog's had a seizure and they're frustrated that you would dare question them. It's just commonplace, right? But what clients don't realize is there's a lot of seizure mimics and there's lots of different types of seizures. So what I do when I start asking people about the character of their dog's seizures is I say to them, I I'm understanding that your dog has a seizure, but I need to know all the different details about that seizure so I could understand what seizure type it is. And then not only will I know better what seizure type it is, but perhaps I can come to better conclusions about the right medication to give. It's not completely accurate. We're not in the place that the human world is where we can say this type of seizure, this type of drug. But what it does is enables you to one, understand the seizure itself for future treatment. But more importantly, it helps you differentiate from other things. Now, certain things are classic seizures, right? Like this Rottweiler is having your classic seizure. It goes into a tonic phase where it gets really outstretched, and then you're going to see it go into convulsions. Is this one a seizure? You betcha. Classic seizures. So let's look at what seizures can look like. Sometimes you get the simple focal seizure. The simple focal seizure is just when you have a single group of muscles kind of all firing repetitively. And the reason that happens is that normally our neurons are talking to each other like they're having a little conversation, like a little cocktail party. But what if some members of that cocktail party would just start screaming all at the same time? Then you would get a focal seizure. And if that happens in your right motor cortex, then maybe your left hand starts doing this. Or if it happens in your right motor cortex, maybe you feel spiders crawling on your arm. So that's what a simple focal seizure, and it can become more intense like this. Skipped it, sorry. Your simple focal seizure can go to that. It's being tricky. Oh, PowerPoint. Um, it can go into this. Your complex focal seizure, and that starts affecting areas like the limbic system. And so you start seeing autonomic dysfunction, hypersalivation, increased heart rate, decreased heart rate, pupils going in and out. That's called hippus, vocalizations, loss of urine, loss of bowel function, all those sorts of things. Watch this dog. It's partially conscious. And I think that's a misnomer or a misunderstanding about seizures. Sometimes people think dogs with seizures have to be unconscious. That's not completely accurate. But what we are most familiar with is the one that the Rottweiler or the boxer had, the generalized tonic-clonic seizure, which starts with the stretching and then it goes into these compulsive paddlings, often associated with the face being drawn back, often associated with lots of drooling, those sorts of things. They tend to last about 2 minutes. And if you remember this cat, you'll notice that this was the simple focal seizure cat, and it's very common for them to generalize. So that's what a seizure would look like. And I like to present some things that look like seizures, but aren't. So if you've never seen this condition before, these dogs are just having this kind of to and fro movement of their head, very reminiscent of a seizure. The dogs are very aware of their surroundings. And what you notice about both of these dogs is when they were provided with a stimulus, whether that's a food or a loud noise or a pet, the behavior went away And then when the stimulus goes away, the behavior starts to come back a little bit. This is what's known as idiopathic head bobbing. It's probably the most common seizure mimic that we see. It tends to happen in bulldogs, but it can happen in any breed, usually middle-aged dogs. And there's two characteristics of the condition. One is that it tends to affect dogs that are at rest. See this very sleepy bulldog. And then the other is that if you give them a big enough stimulus, whether that's something desirable like a treat or a loud noise, it'll stop for a second and then it'll come right back. Pro tip, this tends to happen after anesthesia as well. So if you have a dog waking up and they're doing this after your spay, don't freak out. They had this as an underlying condition, and you basically exacerbated it when you put them under anesthesia. It doesn't require an examination with a neurologist. It doesn't require imaging. It's generally a cool party trick and will get better with age, though never completely go away. The exception to that is in very senior dogs. There was a recent abstract that came out through the American College of Veterinary Internal Medicine, which showed that some of these dogs could have a structural lesion. So if you have a dog that has other clinical signs or is getting into their senior years, maybe it does warrant a workup. The other condition that seems to be the biggest seizure mimic and one of the hottest topics in veterinary neurology right now are these conditions. And these conditions were thought of as seizures for decades until we started having the most valuable tool we have in neurology, the iPhone, or to be agnostic, the mobile device. It's not the MRI because what it enables us to do is see these events. Now, when you watch this cat, what you'll notice is that he does have the stretching, but look how he has all that flexion in his limbs. And the difference is that there's no autonomic dysfunction. The cat's not hypersalivating. It's not doing anything with its face. And these can last for a really long time. We see this in dogs as well. And you'll notice that they're reminiscent of seizures because they come out of nowhere and they have this motor dysfunction associated with them. Do you see that? But you'll notice it's not the convulsion and it's not extension. It tends to be more flexion. This is a group of diseases that's getting more recognition called the paroxysmal dyskinesias. We used to see them in certain breeds. Scottish Terriers, guess what they got? Scotty cramp. Or King Charles Cavalier Spaniels got episodic falling disorder. Or Border Terriers got Border Terrier disease, cramping disease. These movement disorders are also described in the human world, and we're just putting them under this big umbrella of paroxysmal dyskinesias. So we're learning more and more about them as we go. And there's two mainstays of treating these guys. One of them is to put them on a gluten-free diet. Now, that is not going to be effective for most of these dogs. However, in border terriers, it was found that the paroxysmal dyskinesia is related to a gluten sensitivity, likely because of co-localization of the genetic markers that cause it. And so a lot of times we'll put them on Royal Canin Ultimino or a similar diet. The other therapy is some type of membrane stabilizer, a sodium channel blocker, or whatnot. Carbonic anhydrase inhibitors can be considered, but lately, me and my colleagues have been leaning a lot into zonisamide, which is, yes, an anti-seizure medication, but seems to be somewhat effective in abating the clinical signs associated with this condition. There are tons of other conditions that can look like seizures. Syncope can look like seizures. Narcolepsy can look like seizures. Vertigo or vestibular events can look like seizures. If you've ever seen a person try to get up from fainting, they can make some weird movements, and that is reminiscent of them. Even myasthenia gravis or neck pain. And I don't know if you could see it, but my little poodle is behind me. And when he falls asleep, he starts kicking and flailing all over the place. You as a veterinarian might say, well, that's just, moving, running, chasing after squirrels while he's sleeping. Dogs as a species have much more sleep disorder, motor manifestations during sleep than other species. And it can be very confusing to clients differentiating sleep or REM disorders from seizures because they both tend to happen at night. So when you have a sleep disorder, it might behoove you to ask your client, well, can you rouse them from that event? If you can, then it's probably not a seizure. Are they hypersalivating and having other other autonomic dysfunctions? That wouldn't be a seizure, those sorts of things. Do you see why it's so important to try to differentiate seizures from other things? Don't just chalk it up to that. Let's say you've determined it's a seizure. You've communicated with the client that what a seizure is, that it's basically the brain being pissed off by something. Often I'll call it the cough of the brain. And then I start saying to clients, think about coughs. Coughs can happen because you have pneumonia or because you have a cold or you have asthma or allergies. Seizures are the same. Seizure says, hey, my brain's not happy about something. Now I need to figure out why my brain's not happy. Because a lot of them will come in thinking, man, my dog has epilepsy, it had seizures. So, what are the different types of seizure events? There's different ways of classifying the causes. The old school way is metabolic versus structural versus idiopathic. The newer way is reactive versus non-reactive. It doesn't matter. For the primary care clinician, this is how I would compel you to talk to your clients. I would say there's three categories of things that can cause seizures. Something outside the brain that's irritating the brain can do it. Something that's inside the brain irritating the brain can do it. And idiopathic epilepsy. So, for the generalist, for the primary care clinician, for all those technicians out there, thanks for being the backbone of our profession. The metabolic encephalopathies, the problems outside the brain, are the place where you have a chance to intervene. This is if a dog ingested a toxin. This is if a dog has a hepatic disease or a portosystemic shunt, which leads to too high of ammonia and other metabolites in the brain, severe electrolyte abnormalities, hypoglycemia, severe uremia, those sorts of things. So, if you have a dog with seizures, your minimum database should include essentially a CBC and a chemistry, but don't sleep on ammonia or bile acids. In general, dogs with liver dysfunction that leads to hepatic encephalopathy will have some signs on the CBC or the chemistry. Maybe they have microcytosis. Maybe they have an elevation in ALT and ALP, but there's no replacement for an ammonia bile acids, and they can sneak up on you when you're not looking. So be sure to do one of these two tests when you're looking at an epileptic in your place in your clinic. And then, if you are suspicious of a metabolic encephalopathy, remember to supplement hypoglycemia, careful correction of electrolyte abnormalities, hepatic encephalopathy therapy, which we're not going to delve into here, but I'm sure you know best practices for that, detoxification if there's a toxin exposure that could be undergoing it. Most my experience is most primary care clinicians are very good at identifying metabolic encephalopathies and treating them. But I think the place where some of my colleagues maybe struggle with is recognizing and differentiating structural encephalopathies or problems inside the brain with idiopathic epilepsies. So these are some dogs that might make you pause and say, hey, I shouldn't just throw these dogs on some drugs. I should investigate this. One of them is the most obvious. If you see lateralized signs like this dog compulsively circling or behavior changes, happy dogs become angry, angry dogs become happy, looking off into space, seeing less attentive, losing learned behaviors. All of those should be signs like, hey, this is not epilepsy. I should be doing something different here. That's important. Second group of dogs that should make you skip a beat, dogs that are younger than 1 or older than 6. Do we see epileptics younger than 1 and older than 6? Absolutely. But the frequency with which we see them outside those age limits just plummets. I think the numbers right now are that if you have epilepsy and you're a dog between the ages of 1 and, or rather, if you have a seizure and you're a dog between the ages of 1 and 6, your chances of being epileptic are over 83%, I think the number is. Outside those age barriers, it becomes much, much less common. So warning bells should go off if you have a dog younger than 1 or older than 6. The third one is the one that is missed most often, and it's the at-risk breeds for inflammatory disease. So dogs, more than other breeds, are predisposed to immune-mediated or autoimmune meningitis, which when you say meningitis to a client, their brain immediately goes to the elementary schools where they're getting an infection of a bacterial called a meningococcus, and that's what they're thinking of. But you have to twist their minds a little bit and make them recognize that meningitis just means inflammation of the meninges, or meningoencephalitis means inflammation of meninges and brain. And that can sure happen from different types of infection, but in dogs, the vast majority of the time it's a sterile meningitis, meaning immune mediated, where the immune system is attacking the nervous system inappropriately, not dissimilar from IMHA attacking the blood. Now, The dogs that seem to be affected by this most are the middle-aged toy breed female dogs, Yorkshire Terriers, Maltese pugs, but I see it in golden retrievers. I see it in doodles. I see it in pit bulls. It can be lots of different breeds. And so if you see a breed which doesn't fall into the classic epileptic range, like these toy breed dogs, you might want to consider doing more than just throwing them on anti-seizure medications. When I have the opportunity to lecture, I'll say to my colleagues, how many of you guys have lost a dog to epilepsy? Many people will raise their hands, and I say, and how many of those dogs were a toy breed middle-aged dog? And most of the hands stay up. And it's because dogs can die of epilepsy, but much more commonly they die of an underlying disease. And then my favorite is the concerned owner. I think we all remember in veterinary school learning, listen to your clients, and we say yes with one hand, and then we probably don't do it as well in practice as we should. And I like to share the story of Maya. She's a 7-year-old female spayed. Um, she's a 7-year-old female spayed Siberian Husky, and she presented with her owner for a single seizure. Now, I said she's 7. It's a little older than I would expect, but as a single seizure Siberian Husky, which by the way is one of our most common epileptic breeds, I said, I don't think we need to work this up. And she said, no, we're working this up. And I said, and she was an OBGYN, like very well educated. And I said, well, tell me why. I mean, my neuro exam was normal. I'm only seeing one seizure. I don't think we need to get so aggressive that we do anesthesia and this high cost procedure to investigate this. And she said, something's wrong with my dog. And I said, well, tell me what's wrong with your dog. And she said, I don't know, but something's wrong with her. And I said, okay, if you want to do this, we'll do it. We'll take your money because I'm a smart neurologist and I know better than you. Well, turns out that her dog had a massive brain tumor despite the normal neurologic examination. Do you see it right here? This is the brain in cross section and transverse, and this is a big end plaque meningioma. So it turns out she knew better. So you have to listen to your clients. And you know, seizures are in many ways a blessing. And people look at me when I say that and they say, what are you talking about? That's crazy. Well, consider this. Um, if you were to have a brain problem like a colleague of mine did, you might taste triangles. You might smell red, you would describe different things where your brain was acting incorrectly. Dogs don't do that. In fact, they're going to do everything to prevent showing you signs of dysfunction. And so seizures can be a nice early warning indicator that there's a bigger problem in the brain. And I'll stand on my soapbox and beat this drum. If more clients would pursue advanced diagnostics, the ones that would have otherwise, if more clients would pursue advanced diagnostics early, then we as a profession would be much better at treating brain lesions than we are now. Because most of the time, when we get dogs that have brain lesions that lead to seizures, the clients have waited until they're stumbling, falling, turning, having locomotor dysfunction. And the consequence of that is by the time we get to it, it's too late. The mass is too big. So recognize that if you see any of these 4 categories, you are giving your clients an opportunity to recognize a problem way earlier. Now, of course, whenever we talk about neurology, we have to consider that MRIs are expensive and they require anesthesia, and there's all these other considerations that go into it. But what a disservice we're doing if we don't at least offer that to our clients, educate them on that process, and move forward from there. So, if those are the 4 categories of dogs that should make you skip a beat, which cats should make you skip a beat? Well, all of them. Epilepsy in cats is not super common. And so when we have cats with seizures, whether it's kind of these moments of hypersalivation and not paying attention, or major neurologic deficits like walking into garbage cans, recycling cans, of course, those should be reasons that we investigate these patients. Okay, so dogs and cats. Now we've talked to the clients about, is this a seizure? We've talked to them about the different causes of seizures and our index of suspicion of if this is epilepsy versus something else. But then the priority becomes, well, how do we get these darn things to stop? What, and then I'd counter to you, why do we need these things to stop, right? I mean, they're not good to watch, but a lot of symptoms happen and we don't go rushing to the Cubex to fix them. I mean, when was the last time you went running to the pharmaceutical cabinet to grab the Imodium for diarrhea? There's a reason why we want to treat seizures as quickly as possible. The reason why it's so imperative to treat seizures as quickly as possible is they're one of the few symptoms that actually has major consequences in and of themselves. Coughing, sure, if it's intractable enough, could cause its own problems, but it's just a symptom of something else. It's not that big of a deal other than its annoyance. Seizures, in many respects, are more dangerous potentially than the thing that causes them. And the reason they're dangerous is that the neurotransmitters that are normally making our brain function can flood synapses, joint junctions between two brain cells, and cause damage through something called excitotoxicity. And a bad seizure might never stop. And there are rare scenarios where it can lead to death. One of the main reasons we want to stop seizures is because we recognize that seizures make the next seizure more likely. This is called kindling or mirroring, where the brain tries to match itself. And so if you have a seizure on the one side of your brain might start to seizure on the left side of its brain. So we're trying to minimize this. And the other reason we want to minimize it is what I alluded to when we were talking about Mikey. You know, this is changing these clients' lives. Not only are they more stressed than the average person, but they also perceive their dogs have a bad quality of life. It's a really big deal. And I've said this before, I'll say it again. I went into veterinary medicine because I loved animals, and I fell in love with veterinary medicine because I love the people that care for them. It is such an opportunity for us to support these people. And at the same time, the classic move for seizures is here's some meds. I've never met you before. Give your dog these meds every day, twice a day for the rest of their life. And by the way, if you forget a dose, your dog's going to seizure and it's going to be your fault. And by the way, these drugs aren't perfect. They're not going to work great. We just want you to give them every day, check levels, make sure they don't become toxic, and then, good luck to you. Hey, think about that. Epilepsy's tough. It's tough on the clients and it's tough on us for our communication and our continued commitment to their care, but it's so important. So some colleagues of ours created a consensus statement on the management of emergent seizures, and I wanted to share with you some of this data. They took all of the data that's out there and the current evidence, and they basically put together a consensus statement to talk about best practices based on the evidence. So one piece of evidence, which used to be novel, but I think most of us already know, is that midazolam or Versed can be better than diazepam or Valium. Valium used to be the go-to drug because it's lipophilic, and since it's lipophilic and the brain's fatty, it makes sense that it would be more effective. And midazolam is water soluble, and so it shouldn't. But the numbers sift out that it's actually potentially more effective than Valium. It's more potent, and it can be given in the nose very effectively. The recent literature suggests that giving it in the nose is nearly as good as giving diazepam in the vein. So no more putting dogs in figure fours so you can get a catheter in, so you can get the drug in. If a dog comes in seizuring, get the midazolam on board. And when you're going to see these slides, green doesn't mean good and red doesn't mean bad. Green means we have great evidence to support this suggestion. Yellow means we have mediocre evidence to support this suggestion, and reds means we have poor evidence to suggest this is a good idea. So in that consensus statement, obviously cats are underrepresented, but that doesn't mean no less that it's the drug we should use. And here's the dosings up top. Now, consensus statements are based on evidence, which is limited by the papers and manuscripts that have been created. And the one place where I depart from the evidence is that it suggests that you should give these benzodiazepines and then wait a long time and then give it again. I don't think so. I give a dose and then I give it again. I wait maybe 10 seconds and then I'll give it again and again. And I invoke my mentor, Rod Bagley, phenomenal educator, who suggested that you shouldn't be a benzodiazepine whim. Anyone ever kill a dog with Valium or midazolam? No. So I will push 1, 2, 3, 4, 5 doses of midazolam in succession before I say to myself, this isn't working. After you've given them midazolam, and maybe you've put them on a CRI because you want this constant rate infusion so that you can maintain the effectiveness of these drugs because their half-life is so short. You got to get something else on board that's going to be longer lasting, and that can be Keppra or phenobarbital, and those are the doses there. Um, Both of those drugs have nearly instantaneous value and long-term value as well. The third drug was in the consensus statement, fosphenytoin, and it's a drug that most of us don't have access to. So I don't know a lot of clinicians that use it. The third line agents, so let's say midazolam is on board, but it's not cutting it, and you've given your second line agent. This is where the consensus statement really shines some light on some new ideas of what we should be doing. Ketamine and dexmedetomidine should be your next go-tos. Both of them are very effective anti-seizure medications. Dexmedetomidine has the value of potentially even being neuroprotective. I prefer ketamine personally because I don't like dealing with the challenges of the alpha 2s. But I've had to put dogs on both. Valium, an underlying dose of phenobarbital, and then ketamine and dexmedetomidine. And by the way, if you have a dog that's these are not one or the other. If you have a dog that's having intractable seizures, give them both Keppra and phenobarbital. They're likely additive. Okay, so if a dog has failed phenobarbital, Keppra, midazolam, CRI, and then those two other ones, now you can start reaching for some other drugs. But I'll tell you, I think that your chances of successfully abating these seizures are going to be pretty poor. Propofol used to be a go-to anti-seizure medication. It's a great anti-seizure medication, but it's less favored than those other two. And of course, the concern is that you can be basically putting these animals under anesthesia while they're still having seizures. So it's just a concern. And then, pentobarbital and inhalants like isoflurane could be considered. And if you were my colleague and we were consulting together on what to do with that case, I would be telling you to have quality of life conversations with the clients. So it's just something to be mindful of. Now, as you know, Zomedica has sponsored this, and they've been a great advocate for our hospital, which I'll tell you about at the end. Um, and one of the greatest components of our partnership has been access to these units here, the Vet Guardian. So for those of you that aren't familiar, the Vet Guardian is kind of this weird looking box that measures temperature, pulse, and respiration through Doppler technology. And we take tremendous value in that we use it on our postoperative patients so we can monitor them as we're recovering. But they're awesome for patients with severe status epilepticus or other types of seizures. One, because we can monitor their vitals as they're on these drugs that have major suppressive activity to the cardiorespiratory centers. But the other cool thing about them is it's a running video. So if my team member says, hey, I think this dog's having a seizure, and I'm at home, I can actually pull it up on my iPad or my computer, and we can watch these videos together in perpetuity. We can see what's happening to the other vital parameters and make decisions based on that. So although I think the intention of this is for critical care and postoperative recovery, we've certainly used this technology for epileptic patients. And I think it's a great way to monitor them, specifically as we're hitting them with drugs like dexmedetomidine and ketamine. So we can talk about any of the use of the Vet Guardian at the end of the conversation here, but I just wanted to give a nod to it because it's an essential part of our epileptic management um, as we move forward. So there it is. There's a little cool cartoon and it makes it look beautiful. It's nice to be able to see our patients over and over and over again. Now, let's say you're monitoring the dog with a Vet Guardian and you've got them under seizure control. What are you going to do next? Well, the next thing to do is start backing off those drugs that are suppressing the seizures through constant rate infusion. And if you have like Dexmed or ketamine on board, you're going to back those off first. And our general scheme, which is not evidence-based, is we'll usually cut the drugs in half for anywhere between 3 to 4 hours, and then cut them in half again for 3 to 4 hours, and then discontinue them. As you can see, if you get to multiple drugs on board, it can take a long time to get them off these medications. But a lot of the kind of belief about seizures is that once they're amped up, it can take a while for the seizure threshold to return to normal. And so taking your time to get away from these medications is not a bad idea, as long as you're remembering that you must have a long-term agent on board, phenobarbital or Keppra, and frankly, probably both. Some clients will ask me, or colleagues will ask me about clonazepam or clorazepate, these benzodiazepines that are longer acting as quote unquote cluster busters. We just don't have a cluster buster, if you will. And my colleague was, and pseudo mentor was the one that recommended we consider these medications for dogs. But there's really a paucity of evidence to support their value. And a lot of times I struggle where clients say, yeah, my dog's not seizuring, but he sleeps for 3 days straight. So I think the jury's still out if clorazepate should be a drug we should be considering. You know, so that was a conversation or a foray about emergency seizure management. But I think what most of you likely deal with is not emergent seizure management, just general seizure management. And it used to be this really difficult conversation. Do I start anti-seizure medications? Do I not? Do I deal with the side effects? Keppra came along and it really kind of changed the way we think about things. But when you're thinking about treating seizures, two things. One is I think it's all about expectations. And expectations for clients means telling them, I am not curing your dog of seizures. It will continue to have seizures. The function of these drugs is to decrease the severity of frequency of these seizures and the severity and the duration and the postictal effects. So that conversation has two values in it. One is it lets the clients know that you are managing this, not curing this. And the second value in it is to twist the veterinary approach to seizure management, which also affects humans, which is how many times, when was your dog's last seizure? That's not enough. And despite the fact that when the FDA approves drugs, it makes decisions based on how frequent the seizures are, I always say to clients, which would you prefer? Would you prefer to have one nasty seizure that lasts 10 minutes and your dog is disoriented for 3 days? Or would you rather have three smaller seizures that last seconds and then your dog goes right back to normal? And invariably, they choose the latter. So just remember when you're thinking about seizure management, success does not have to be spacing these things out significantly. I mean, ideally it is. But what it really could be is making them less bad or less long, or the post-ictal period, which can be worse than the seizure, less. I'll start anti-seizure management in any dog that has a really bad seizure, or has an underlying cause for them, because the truth is that once the air hits your brain, it's never the same. Once your brain has been injured, it is always predisposed to having seizures, not dissimilar from a cough, right? Once you've had a lung injury, you're always going to be predisposed to challenges with ventilation or coughing. The other group of dogs that will be candidates for starting anti-seizure medication after a single seizure would be the high-risk breeds, the Australian Shepherds, the Border Collies, and a bunch of other dogs like that. I mean, those dogs are just so difficult to control. The remainder of dogs, we often will wait until the dogs are having seizures more than once every 3 months. And the rationale behind that is most anti-seizure medications aren't going to be able to space that out much longer. So if I have a dog that has seizures 4 times a year, I very much may consider not giving any anti-seizure medications at all. Um, and the note at the bottom is just a reminder, seizure management's unique, right? I mean, how many diseases do you have that may or may not happen, but because they may or may not happen, you decide to give medications every day, twice a day, sometimes 3 times a day for the rest of a dog's life. I mean, it's kind of primitive if you think about it. And in the human world, epilepsy management's so much more advanced. I mean, they will have humans that will wear cowls or even have a surgery where an electrical strip is put under their brain and then a wire goes down their side to a little beeper on the side of their hip that says, hey, you're not going to have a seizure today, or your chances of having a seizure are really big. Take this med today. And in dogs, we just put them on constitutive therapy and don't think twice about it. So just something to think about. And if you're interested in considering other types of seizure management, read this book. Dr. Sanders, my colleague Sean, came out with this book, the second edition, very recently. And if you're intrigued about seizures, the history of seizure management, the best practices in seizure management, and where the future may lead us, check out this book. It's pretty cool. And Mikey's story is the preface, which is fun. Uh, this slide is a reminder when we get into seizure management. Well, why don't we have the perfect drug, right? When you think about Addison's disease, you're trying to think for the magic bullet that's going to make Addison's disease better or Cushing's disease better or something like that. Um, in veterinary, when it comes to epilepsy, human or veterinary, there is no perfect drug. And the reason there is no perfect drug is epilepsy isn't one disease or two diseases. It's likely tens, if not hundreds of diseases. That's why it's called a garbage can diagnosis. Just because you have a seizure, you're going to say, well, you have idiopathic epilepsy. Well, in the human world, they've identified multiple epilepsy syndromes in children alone. And within those epilepsy syndromes, literally hundreds of genetic markers that tell us what type of epilepsy they have. So, for example, if you're a human and you have mesial temporal lobe epilepsy and you have one of these genetic mutations that causes it, they're going to say, well, based on your genetic mutation and the semiology of your seizure, we're going to put you on a specific medication. And in veterinary medicine, we walk out of the room and we say, hey, here's some phenobarbital. It shouldn't surprise us that some dogs respond well to one medication and some dogs respond well to another. It doesn't mean one's better than the other. And if you're looking for the magic bullet here, you're missing the mark. Recognize that it behooves us to have multiple tools in our toolkit, and a lot of them can be valuable in treating epilepsy. And the reason for that is this very complicated figure, which talks about the different mechanisms of action. Each one of these anti-seizure medications works on a different part of the neuron, whether it's the cell membrane or the channels or the release of the neurotransmitters. And maybe we can start hitting these things at multiple sides, which is an opportunity for me to bring back some oldies but goodies. Keppra came along, and then our oldies but goodies like phenobarbital and potassium bromide got forgotten. In fact, when I talk with young veterinarians, many of them don't even know what potassium bromide is. They've never used it before. And the reason is Keppra is super safe and relatively effective. Older drugs can take a little longer to work than Keppra. Um, their efficacy can be variable, though usually better than Keppra. They have an expected side effect profile. They can have really rare but catastrophic side effects. And you need to keep that drug in a narrow therapeutic range. So it can be costly to keep it where it needs to be. But if we throw the baby out with the bathwater, then we're missing the mark on drugs that are valuable. Phenobarbital and potassium bromide are extremely effective drugs and synergistic with a lot of our modern anti-seizure medications, and they're veterinary specific. In fact, finally, potassium bromide from PRN Pharmacal just got FDA approval for use in dogs. Now, the oldest anti-seizure medication of all time, right? So now we have veterinary formulations, which are really exciting. Um, oh, I'm going backwards. Sorry about that. So when we're thinking about the oldies, remember phenobarbital. It is our best long-term anti-seizure medication, bar none. And I want you to consider using it frequently. 3 mg per kg to 4 mg per kg BID. It's extremely effective. And when I talk to clients about phenobarbital, often I'll share with them this general concept. And the general concept suggests that phenobarbital can be below the range that helps seizures, in the range that helps seizures, or in a range that's toxic to their dogs, regardless. And I've often joked that I can stop any seizure with phenobarbital. It's true, I can. Their liver might explode the next day, but I can do it. Recognize that the therapeutic range, the true therapeutic range for dogs could be toxic to them. And so clients need to understand that. The main value for clients of understanding this fancy little chart is, why do I need to give Keppra 3 times a day? Why do I only need to give bromide once a day? It's because of this. You give it and it spikes, and then the body tries to get rid of it, and then you give it and it spikes, and the body tries to get rid of it. And you need to give it this frequently to stay within this narrow range. Otherwise, it's going to dip and fall, trough, and dip and trough. And that usually resonates with them. It also helps them understand why they need to give it consistently so that it stays at this level as opposed to this level down here. True steady state. 5 times your half-life, essentially. Now, this is the part where I want you to pay attention. These therapeutic ranges are not super helpful. When it comes to phenobarbital, the dose matters, but every liver is different, which means that every dog is going to metabolize it different, just like people metabolizing alcohol. And um, when you give a beagle and a greyhound 3 mg per kg of phenobarbital, I guarantee you their serum concentrations are going to be different. So don't call your neurologist and say, well, it's in the therapeutic range. Yeah, that's junk. What I care about is what is the number, because I want to make sure that I'm pushing it as hard as I can without getting into the toxic range. I like to invoke the showcase showdown. You want to push these drug levels if you haven't gotten seizure control to their highest level before you give up on them. Now, that means if you have 19, like this dog does, 19 micrograms per milliliter, and then you've controlled the seizures, awesome. Now it's worked and you have room to grow. But if you haven't controlled the seizures, you got to push that drug to the mid or even the high 30s before you say, yeah, phenobarb didn't work for me. It's important to get it as high in that therapeutic range as possible. Now, cats are also very amenable to phenobarbital. I would encourage you to consider it. Their therapeutic range is a little bit lower, which is fine, but they actually tolerate higher doses relatively well compared to dogs. And the most exciting thing about phenobarbital is that it can be given orally once per day in cats, which is a game changer because, as you can imagine, pilling your cat twice a day for the rest of their lives is difficult. The other drug I want you to remember is bromide. It is a very effective drug and has so many advantages that other anti-seizure medications don't. It's a salt and it has some side effects associated with it. I'm not denying it. Increased thirst, increased urination, wobbliness in the back legs, and sometimes kind of a dopey appearance. Rare scenarios of dermatitis, never seen it, and pancreatitis, which is a little bit more common. So I'll avoid this drug in dogs with high triglycerides or a history of GI disease. And I also remember that it is toxic in cats. It doesn't require a conversation, but it's just a bad drug for cats. Don't use it. But this is the slide that I want you to see before, because we're getting towards the end. I like phenobarbital because of its effectiveness, and I like it in animals that have renal compromise or are predisposed to pancreatitis. Sometimes even small dogs seem to do better with phenobarbital for some reason that I don't understand. But when it comes to bromide, it's great for young animals that you don't want to tax their liver for their rest of their lives, or for the non-compliant owner because it's given once a day. It has such a long half-life that if they miss a dose, it's going to be okay. And my favorite part about it is it doesn't have this toxic range when you reach this high therapeutic level that you can't go back from. You know I get the call from the client that says, I need a phenobarbital refill. I'm out. And I'm like, yeah, but it's Friday at 6 p.m. and we haven't tested your dog's levels in a year. I can't refill that. With bromide, it's never a worry. You can refill it, and you really only have to test levels if it's ineffective or if you're getting into toxic symptoms, which you're going to see. So it has a lot of value there. It's great for animals with liver dysfunction or a history of IMHA and hypothyroid animals because, as a reminder, testing thyroid levels in dogs with phenobarbital can be tricky. Obviously, Keppra is a fantastic drug. I'm not going to belabor it. It's a safe drug. I'd say it has moderate effectiveness. So it's great to combine with other drugs. But if you have a severe seizuring patient, this is not your go-to drug on its own. Um, Another drug that's gaining some traction, it was really popular for a while, and then its popularity went down. And the reason why it was so popular is because it was a BID drug and Keppra was TID. Then Keppra had extended release, zonisamide became less popular, and now it's gaining traction again because there's some nice evidence coming out of Japan of its value. The problem with zonisamide, of course, is that it shares an enzymatic system with phenobarbital. So just be mindful of that. If you have a dog at the high end of the phenobarb range and then you decide to add in zonisamide, the level of your phenobarbital is going to go up. And so you could push it into the therapeutic range. So just be mindful of using those two drugs together. There's lots of other drugs on the horizon, and we're kind of out of time, but I just want to share with you that just keep an eye out for them. Imepitoin is a European drug that cannot get FDA approval for the United States, but it will be here eventually. It's very popular. It's used nearly as frequently, if not more frequently, than phenobarbital, and it has a lot of value to it. Topiramate, the number two drug used in humans, also very exciting for the veterinary world. It will likely come out with a veterinary formulation eventually. The challenge with topiramate right now is that it has such a short half-life that theoretically it should be given 5 or even 6 times a day. But as soon as we can come out with a release or a formulation that can be slower released in dogs, I think you may see it as a possibility. And then the last drug that I want to keep on your radar is going to be CBD. I know CBD sounds scary. I know people get weirded out about using cannabinoids in dogs, but there's some really nice evidence coming out to suggest that it could have value. What we know is that you have to give it at a relatively high dose, 6 mg per kg to be effective. And what we also know is that outside of our, veterinary formulations, which have, some good quality control, it's very variable how that's dosed. And so I would just remind you to use a veterinary specific product when you're offering CBD, and also check into your local state regulations, which are constantly shifting about the legality of using CBD. But from an evidence-based standpoint, it has value. Um, so, you know, stop these seizures right away. There are steps to get these guys to stop. I think it's really important. But what I really want you to remember, and these are not the take-home messages that I really want you to have, what I really want you to remember is that this is about communication. This is about helping clients understand what's going on with their dogs, empathizing with them. And a lot of times it's really about letting them off the hook, helping them understand um, that it's okay and that their best is good enough. So I just wanted to share that with you guys. And for those of you that might be interested in kind of more information, check out animalneurology.com. We do a lot of continuing education seminars here on site, weekend seminars where you can learn everything about neurology beyond seizures. And we're excited to offer neurology boot camp, and you can't spell neuro without ER, and all these different offerings that are going to hopefully empower you to be the best neurology practitioners you can be. So I appreciate Zoometica giving me the time to talk to you all, and I'd be happy to answer any questions if there are any.